There. How you doing, folks? We are live and it's Tuesday evening, and you are exactly the place where you're supposed to be. It's Fertility with Fink, 5 o'clock Central Time, which means 6 o'clock on the East Coast, and 4 o'clock in the mountains, 3 on the west. My name is Dr. Randy Fink, and I am a fertility gynecologist here at New Life Fertility in Pensacola, Florida. This evening, I am live from Dothan, Alabama, where we have one of our really wonderful uh, offices, satellite offices. We are in Pensacola is our home office, Dothan, Alabama. We've got Mobile, Alabama, and also Pensacola, Florida, or rather also Panama City, Florida, and Tallahassee, Florida. But tonight it's Dothan, so you may notice that things look a little different than they normally look because I'm sitting here in a hotel room talking to you. As we do every Tuesday evening. It is my favorite place to be with my favorite group of people. So thank you so much for joining me. So happy to see you. Hi, Daisy. Nice to see you this evening. And my mother, the Bama Gal in Mobile, Alabama, just joined in. Thank you for being here. Hey to Wendy. And looks like to Melaine, I believe, or Lane, I think is what that says. Sarah, hello. And Melissa, hi to Macy. We've got a couple of different Instagram feeds here. We've got my Instagram right here, which is Randy Fink MD. We've got New Life Fertility's Instagram. We've got Facebook. We've got LinkedIn. We've got YouTube. We have all different ways for you to try to connect here on a Tuesday evening. If you've got questions about women's health and fertility, tonight is your opportunity to ask those questions, because like every Tuesday evening, we get together to talk about all those things that are really important. And that's things about making a family. That's things about women's health and gynecology, things about obstetrics, having a baby. However I can help you, that's what I am here to do. So what was I doing today in Dothan, Alabama? Well, in addition to, I got to tell you, Dothan is a town, I have never been here. It turns out my brother was actually born not too far from here at a place called Fort Rucker, Alabama. But he was born here. This town has really some great restaurants. I have to tell you, it's very surprising. The folks here, the people are so very, very nice. And it's just really nice to be in such a friendly place. What was I doing today? So I was doing a bunch of different consultations, talking to different people about what their issues are. How does that whole consultation process work? Well, typically what happens is that you visit with us. You schedule an appointment, and that is done through the website, which is fertilityleaders.com. You fill out a little application with some history in it, and then what we do is we get together, we talk either in person or virtually. We get some testing done. We review all those labs together. The way I like to think of it is that we kind of make a whole little kind of a photo album, as it were, about you and all those things that are hormones and mechanical as it pertains to reproduction. And then we sit down and flip through that photo album together and try to figure out what we have to do to help you to get sperm together with egg, because at the end of the day, that is how the magic happens. So today we're spending a little time with some nice people going through their journeys and in sharing some of the details of that stuff and sort of helping to try to piece together where things were not working the way they were supposed to, because by the time folks come to see me, they have had a situation where it hasn't worked. And that's what our job is to do, to put together sperm and egg. Hey to Andre, my friend. It's great to see you. And you called me Dr. Funk. I've been called worse, so that's okay. Hey to Angela, nice to see you. Very happy to see you as well. Let's see what we have. We got some questions starting to filter in over here. Lindsay, it's my pleasure to be here. Thank you very, very much. Would love to hear your thoughts on preparing for IVF and optimizing health before an IVF cycle. Always love talking with physicians on their standpoint. Well, I'll tell you, as it pertains to IVF, really, most of the time, the process of IVF actually allows us to really get through many of the reasons that people don't get pregnant. So what's happened there is that, let's say that we have a case of what we'll call unexplained infertility, and that is sperm appear to be normal. The tubes appear to be open. The uterine cavity is normal. The hormones all add up to doing what they are supposed to be doing, but still sperm is not meeting egg. So maybe that's what we'll call unexplained infertility. What's happening in that situation is that sperm are coming in through the vagina. They're going into the cervix. They're into the uterine cavity, entering to an opening of a fallopian tube. And very quickly, they get inside the tube. They swim up the tube. The egg has been taken up into the ovary, but for some reason, sperm and egg aren't shaking hands. And when they can't shake hands together in the body, then that's where IVF comes in. And that's where we introduce sperm together with egg in the laboratory. And doing so really overcomes many of the problems that we often think of as it pertains to fertility. So certain male factor type issues. So if there's an issue with the DNA, for example, in the egg, and that's something that we call DNA fragmentation, we are able to select an individual sperm to place inside the egg. And the way I like to think of that is, we have embryologists who actually sit down and interview every single sperm, make sure that their hair looks perfect, their makeup is done, well, and that they're dressed appropriately for the occasion. They have the right senses of humor, and that, they're just generally good sperm. Good sperm make good people. And they select an individual sperm for each egg, which sounds crazy when you think about it. So many of the kinds of problems that we see associated with people's lives, we're able to overcome through the process of IVF. And so, does it require a certain level of health, I think is what you're asking, before you do IVF? And the answer is no, not necessarily. But I think there are some things that you can do to try to improve outcomes. And the number one thing has to do with supplements. If you are familiar, I've written a little book that's called The Vitamin Victory. The book is $7. It's available. It's an ebook. You can get it through the link on my Instagram, Randy Fink MD, my link tree. But I feel very strongly that, there is an evidence-based protocol for what can a handful of vitamins do to help us get pregnant. And the issue is that, well, let's say the sperm that come out today, that sperm was manufactured in the male body about 3 months ago, whereas every egg that a woman has in her ovaries has been there since the day of her birth. Since the day of your birth. And over the course of our lives, the DNA that's in those eggs starts to become less stable. Now, our bodies do have a pretty effective DNA repair mechanism. And I always say that DNA repair mechanism is the very reason that you don't go and get a sunburn and then a week later you die because you're riddled with cancer. Our bodies are able to repair some of that DNA damage. The supplement protocol is designed to help your body repair DNA. There are a few things on that list. Probably the most important one I did a post about just the other day, and that is CoQ10. CoQ10 is really an antioxidant. It is the fuel for the portion of the cell known as the mitochondria. And the mitochondria is the energy factory of our cells. There are two different types of CoQ10. One's called ubiquinol. The other is called ubiquinone. And depending on which type you get, they're both available over the counter, but depending on which one is in the supplement you get depends on the dose that you need. So if it's the ubiquinol form, women need 400 milligrams daily, which is 200 milligrams in divided dose. So once in the morning, once in the evening. If it is the ubiquinone form, it's 600 milligrams a day or 300 milligrams in divided doses. So the number one thing that I see for folks who have already gotten themselves a hold of CoQ10 is that they're taking the wrong dose. They're not taking enough of it. So I feel very strongly in that. Take the correct dose of CoQ10. And if you can't remember that, look at my Instagram, also on New Life's Instagram, for the CoQ10 post that I did just last week, and that will remind you about it. So that's really, I think the most important thing before IVF is to make sure that you've done everything you can to produce healthy eggs. The other question people often ask about is, well, what effect does stress have on my body? And I will say, the struggle is real, friends. It certainly is real, but at the end of the day, we can't get rid of stress. I wish we could get rid of stress, but we can't. Stress is a very real thing in the environment. It has an effect on our adrenal glands. It has an effect on our cortisol levels. But as you know, from sort of looking at the streets or looking in the desert plains of Africa, nomadic tribes, even people who don't have roofs over their heads, they still get pregnant despite some very obvious stressors. So we can't really change the fact that stress is in our lives, but we can try to manage it. So I think managing stress, being happy, and tuning up your ovaries as best you can. Now, when I say being happy, what do I mean about that? Do things that you enjoy. Go to a movie, watch TV, chill out, go work out, do whatever it is you like to do that makes you feel whole and makes you feel happy, because those things really do make a difference in our cortisol levels. And I think that definitely feeds back into the ovaries as well. So, Lindsay, thanks so much for that question. It's a great question. What can we do to optimize? Angela asks, can you have intercourse after an embryo transfer? And the answer is yes, you certainly may. Now, if you've done, there's two types of embryo transfers. There is a medicated cycle, or what we call a programmed cycle, and there is a natural or a modified natural cycle, or an ovulatory cycle. Understand that there's a difference. In the programmed cycle, we are giving you all the hormones your body needs. And by doing that, we're also turning off your body's ability to make those hormones themselves, because we want to control every variable. We don't want to leave anything to chance. And so we are giving you all of that hormone. In that situation, you have no ability to conceive on your own. If you've done an ovulatory cycle, which is where sometimes we'll induce ovulation in you, or let you ovulate on your own, the advantage of doing that is then you make your own progesterone hormone. You make your own estrogen, you make your own progesterone. You don't have to get the shots. What happens in that scenario is that if you have intercourse, there is theoretically a possibility that even though we placed an embryo inside of you, that you could still spontaneously conceive on top of that. So I have seen situations, in fact, more than once, I've seen a situation where someone will go and do an ovulatory or a modified natural frozen embryo transfer cycle for a euploid embryo. Let's say that they know that they put in a male embryo. They do the embryo transfer and they have sexual relations, and lo and behold, they get pregnant. But when it comes time to do the ultrasound, they find out that the baby's a female. And they say, whoa, what happened there? Did they give me the right embryo? And so naturally, you're kind of going to freak out about that, right? Because you want to know, your expectation was that embryo was something different. Well, it's because they had intercourse after that embryo transfer and spontaneously conceived. So, just recognize that it can create some awkward moments. It can create some stress, and certainly intercourse with the vaginal progesterone may be somewhat less than optimum. But the answer is yes, Angela, you definitely certainly can have sex. There's nothing about the act of intercourse that's going to disturb an embryo inside the uterus. Now that said, I wouldn't go crazy, but yes, it is. It is something that's okay. Good question there as well. Hey, Rosa, always good to see you. Can an endometrioma that's 4.5 centimeters shrink after pregnancy and breastfeeding? And the answer is yes, an endometrioma may shrink because after you have had the baby, the hormonal state that may be supplying the hormonal food source to that endometrioma may be suppressed, especially if you're breastfeeding. So you may see that shrink a little bit. If it's 4.5 centimeters, it probably won't shrink a whole lot. So I'm not saying that it's going to go from 4.5 centimeters down to 1 centimeter, but you might see it go from 4.5, maybe down to 3 or 3.5 centimeters. I think that's certainly possible. Yeah, for sure. Does it ever make sense to thaw embryos? This comes from Mags Hagen or Mag Scambor. I never know how to say your name, so I hope you'll forgive me. Mag Scambor. Does it ever make sense to thaw embryos and PG test and refreeze? On transfer number 3, the first pregnancy was a blighted ovum. The second was a chemical pregnancy. Both were untested. I have 9 embryos left in cryo. So the answer to that is yes, it may actually make sense. So what we're talking about here is a situation where you've got 9 frozen embryos and you've had 2 pregnancy losses that were likely the result of a chromosomal abnormality in an embryo. So the blighted ovum is what's called an anembryonic pregnancy, and that is definitely a chromosomal issue. And the chemical pregnancy is also usually because the pregnancy grabs hold. It starts the process happening in the body of being pregnant, but at the end of the day, something's not normal in the pregnancy, and therefore it stops growing. So what you're asking is, could you thaw your embryos, biopsy them, and refreeze them so that you know of those 9 remaining embryos, which of them are chromosomally normal? And the answer to that is yes, you can. There is theoretically a risk to thawing, biopsying, refreezing, and then thawing again when it comes time to transfer the embryos. However, most embryos will do just fine with that. Now, certainly if given the choice, I would say I would rather have you do PGT testing at the onset than instead of having to put, the embryos kind of through all that. But yes, you definitely can do that. And that may give you some peace in knowing that the next embryo you place inside of you is a chromosomally normal embryo. Now, the issue with that really comes down to, well, how old were you when the eggs were retrieved and those embryos were made? Because depending, the relationship between chromosomally normal embryos and age is that the younger we are when those embryos come out, the greater the probability they're going to be normal. So, let's say if you're 23 years old, the need to do that, to PGT test the remaining embryos, is probably pretty low because most of your embryos are going to be normal. It starts to get, a little iffier in our 30s, and things can start to change a little bit there. But I do think it's worth a conversation. And having gone through a couple of losses there after embryo transfers, I think that's not an unreasonable thing for you to do. Yeah, for sure. Hey, to Lexi Younts, nice to see you up in the Carolinas. She says, it's a good book, Dr. Fink. Thank you. You're talking about my book, The Vitamin Victory. I appreciate you saying so, and I hope you are doing well. I know that you've been kind of going through a lot, and we're certainly all thinking about you here as well. Hi to Baby Love, and to Sheila, and to Joy, and to Tanner. Nice to see you guys. Fertility Action, thank you for being here. Melissa asks, Dr. Fink, what are your thoughts on red light therapy before an FET? Well, I got to tell you, I don't know a ton about it other than it's a thing. However, I haven't seen any real strong data that tells me that, oh gosh, I think that's a great idea. So it's one of those add-ons that certainly isn't going to harm anything. It's just red light therapy. But the mechanism by which it works and the efficacy of what it does makes me scratch my head a little bit and say, well, I don't know. And I think we have to be real careful out there, because there are a lot of interventions that people tout, that they will sell to you, because they know that when we are in this situation of wanting a baby so badly, that we'll do a lot of things. We'll pay a lot of money to do a lot of things that may have some questionable value. And so I try to be pretty rigorous about the way I look at those things. And the first question is it going to do any harm? And certainly, it's red light therapy. It's not going to do any harm, unless you slip and fall, going into it and bang your head. But that same thing could happen, getting out of the bathtub or the shower in the morning. So I don't think it's going to harm anything, but the question is, how much is it going to cost? So, if it's a couple $100s a session, a couple $100, really starts to add up. If it's $10, well, $10 is not really a lot to spend in order to maybe get some benefit from it. So I think the thing is that it really, there's not a lot of solid data on it. And that's the kind of thing that I think would be, reasonably easy to do some studies on, because it's not an intervention that's particularly expensive, and it's not something that's dangerous. And so, certainly, why not study it? And so if it's so good, why hasn't it really been studied? I think, there have been some small studies, but nothing large that tells me that, hey, yeah, it's a really good thing, and I think everybody should be doing it. So I would, guard yourself. Depends on the cost, and it depends on the risk. And so, since we know the risk isn't very much, it really ultimately comes down to cost. I don't think it's going to harm anything, but it's hard to say that it's something that everybody should be doing. Let's see. Hello to Ms. MS. Oh, I can't read it. Sorry. Melaine says, Doc, I'm doing a back-to-back cycle. What do you recommend last minute to better my odds? So let's talk about that. What's a back-to-back cycle? Back-to-back is IVF, where you do one cycle, you do your egg retrieval, and then you 10 days or so later, you get a period, and then you start another stim. That's called a stacked cycle or a back-to-back cycle. And what we know is that is, by and large, a good thing. We like for people to do stacked cycles, because think of it this way: the body has kind of figured out what it's supposed to be doing. Now, in reality, what's happening there is that the medication that you use to stimulate your ovaries in the first cycle will continue to help you recruit eggs in the second cycle. So in each successive cycle, we typically do better and better when it comes to egg quality. Now, you may not get more eggs in the second cycle, although you might, but usually, for sure, the quality of the eggs is better in the subsequent cycle. So I think you're really doing everything that you can if you're doing a back-to-back cycle. Sometimes ovarian PRP can be a beneficial thing, depending on what the situation is with your ovaries. But as far as lifestyle choices, you want to continue on your supplements. I would say for sure you continue your CoQ10 and your prenatal vitamin, but do what you have to do to be happy, because that happiness means good things to our cortisol levels. And by the time you get your period, the bloating and the endometrium and all the hormones, everything resets. So there's really no harm on your body to do it. But the other thing to know there is that, going through this whole process certainly is an emotional roller coaster. And I think everybody who is listening or will listen to this can agree that this whole process is an emotional roller coaster. In fact, it's probably the crappiest roller coaster in the entire park, because it bangs your head around, it hurts your neck, it gives you a concussion, you're nauseated from it, you're scared on it, and you don't know when the damn thing is going to end. So that's a roller coaster that's hard to ride. Fortunately, for most of us, and I can say this confidently, for most people going through this process, you're going to end up pulling into the station on this little roller coaster train and getting off with a lovely parting gift, and that is your baby. So that's really what we're hoping for there. Hey to Ariel Eden, nice to see you. Me adore miracle. Me adore miracle. That's what that says. Yeah. Hey to Cynthia. Lenac, nice to see you. Hi, Sadie. Honey Girl says, since miscarrying last year, I have had 3 FETs canceled because my lining is either too thick, too thin, or I have uterine fluid. The docs say it's stress, but should I consider anything else? Well, all right. So the uterine lining, right? So this is the world's best baby blanket. This is the thing where the embryo goes that's going to envelop that embryo and allow it to grow. It has to be a nice, spongy, warm, juicy place. If it's too thin, then that means that the estrogen didn't do its job well enough to create a nice, warm baby blanket. If it's too thick, then it makes me think, well, is there something else that's going on inside that lining? Now, there is a number that we could measure that would tell me that that lining is too thin. We like to see a minimum lining of about 7 millimeters. So if it's too thin, that we know. But there's no lining that is specifically said to be too thick. But if a lining appears to be thick, it makes me wonder, is there a polyp on the inside? Is there some glandular crowding? Is there some overgrowth? What's going on in there? And I would want to look into the uterus. I'd want to take some tissue, have somebody look at it under the microscope, make sure that there's no inflammation, make sure, see physically that there's no polyp or finger-like growth on the inside or a fibroid. That is, I think, pretty important. Stress, I don't know that causes a direct effect on that. And honey girl, I'm a little leery of that answer. When we see fluid in the lining, we often think that that's a result, and that's like the lining is raw and inflamed and irritated. And so that's what some of that fluid is. We can suck a little bit of that fluid out, but honey girl, that's something that, I'd be happy to talk with you more about if you like, because I'm not sure that stress is a good answer for that one, and I never want to say that another doctor is wrong. So I'm not saying that in any way, shape, or form. But that sounds a little strange to me, and I'd want to look into it a little bit more. Let's see. Would a back-to-back cycle help for low AMH patients? And the answer is yes, absolutely. And that's one of the times that we typically do it, because when you have a low AMH, we can predict that the ovaries are not going to respond in a truly robust kind of way, And so one of the ways that we can beat that is by the back-to-back cycle, because we're stacking the medication cycle by cycle, and so it continues to work to help you. The other thing with a low AMH is that, if we're getting fewer eggs, anything that we can do to try to improve the quality of those eggs is going to be important. So, yep, people who have responded poorly in the past and people with a low AMH who might not be expected or predicted to respond super well are all good candidates for a back-to-back retrieval. Is it normal to put on estradiol, to be put on estradiol 2 times a day after a retrieval for a fresh day 3 transfer, even with only a 10,000 HCD trigger and no Lupron? So in most cases, your estradiol level will be sufficient at the time of, for a fresh transfer, at the time of retrieval for a fresh transfer. It wouldn't be unusual in some programs to be able to give you a little extra estrogen support. It wouldn't be unusual, but strictly speaking, is it necessary? You probably have a pretty good lining there, and you probably have a pretty good estrogen level. My guess is that since there are some programs that use a lot of letrozole in their stims, Letrozole will cause your estradiol level to be low. And then what happens? The nurse sees a low estradiol level and says, oh, we have to treat that. And then they put you on estrogen, which is one of the reasons that I don't, it's one of the things that has always kind of been a pet peeve of mine. So I wouldn't say it's a strange thing, but it just may not be a fully necessary thing if you've really thought through what the whole situation is. A special shout out going to Kaylee Gordon, if you are still listening. Kaylee is one of the most wonderful nurse practitioners I have encountered, and she is at New Life Fertility in Pensacola. She is a great soul. She is really a brilliant clinician, and really truly a very caring person. Kaylee, thank you for being here. Thank you for working with me at New Life Fertility, and all the best in the adventures that you have coming up in your life. Lindsay asks, hey, will you be going to ASRM this year? ASRM is the American Society for Reproductive Medicine, and this year's conference in October is in San Antonio, Florida. I haven't decided yet. I haven't decided if I will be at ASRM or not. I would like to actually go and be able to do some interviews for some other doctors and put down some stuff on a big YouTube kind of channel that we're working on in order to just kind of answer all those questions people have about fertility, something that they can always look at and always be able to get an answer to in a quick and succinct kind of way. That's the project that I'm kind of working on now. It'd be nice to do some of those interviews at ASRM, but we'll see how that timing works. Let's see here. Hey to Grace Parola. Nice to see you this fine evening, my friends, the Parolas. Hey, Nurtured Shanna, as always, a pleasure. Wide River. Hi there. Marta Steph. I think that says, well, we'll say, Marta, is there any benefit of birth control right before starting stims? And the answer is sometimes, yes, there is. Many programs will use some birth control or some hormone. And basically, people say, I don't want to be on birth control. I'm trying to get pregnant. Why are you trying to put me on birth control? And the answer is, well, it's estrogen and progesterone that we want to put you on. Right. And to take it in the form of a birth control pill is just convenient because it's packaged together. It's all in the same pill. They're usually pretty cheap, if not free on your insurance. And so it's just a convenient way to do it. So why do we do that? Well, it helps us to be able to control the timing of menstrual cycles so that the timing of the stem start can be something that we have the ability to change, that we can alter it, we can deal with that and make it fit into the STEM schedules. In some places that do a ton of retrievals, well, we don't want to overload the lab. There may be a fixed maximum number of retrievals we can do on a given day. And so STEM starting too many people at once is something that's potentially dangerous, not only for the patient, but for the laboratory and for the embryos. So being able to control that is important. But the other thing that being on some birth control does is I like to think of it this way. Birth control quiets down the ovaries. It tells the ovaries, hey, take it easy, man, it takes all these little follicles, all these little eggs, and it brings them in together, lined up behind the starting gate, so that once that gate raises up and the fillies can start to run, that all those eggs are more likely to grow in a synchronized kind of fashion, that they may grow more together than apart. So if you just started randomly, you may have one egg, one follicle that ends up 16 millimeters. The other is 10. Another one is 12. Another one is 4. They're just kind of all over the map. Well, if we can bring them all in together, bring them back to a particular stage of growth, then we can make them grow potentially in sync. I think we lost a little bit of connection there on this Instagram, but so that's the reason why we do some hormones. One, it's for timing, but two, it's also to coordinate the growth, to suppress the ovaries so that once we start the stimulation process, the eggs tend to want to grow together. It's about 35 minutes after the hour. Boy, it's flying through. We're here every Tuesday evening. And I love it that you are willing to show up and be here, spend this time with me. Please come back every Tuesday at 5 o'clock Central Time, which means 4 o'clock in the mountains and 6 on the East Coast. Fertility with Fink is a production of New Life Fertility and the First Fertility Network. Check out the website for a location nearest you. But better than that, come and see me because I'd really like to see you face to face. Let's see here. Bear and Dove Cookie. Oh, Bear and Dove Cookies, that said. Lovely Onyx, hello. Haven't seen you for a while. Alicia Joy says the first successful FET with donor egg, but sadly lost it, oh gosh, at 9 weeks and 2 days. I'm so sorry to hear that, Alicia. It was a monochorionic diamniotic twin pregnancy. Lost baby B's heartbeat at 6 weeks, being told that that was likely the cause of baby A. Would you agree? And I would say, yeah, the answer is unfortunately probably so. I am so sorry to hear that. You know, there is nothing, there are not nothing, but there are certainly few things that are less fair in this world than to go through the process of IVF, to make an embryo, to put that embryo in, or in this case, to do it, you know, through selecting an egg donor and putting that in, only to have that pregnancy stop growing. And really, you know, it sounds like what happened there. So you did an FET, a frozen embryo transfer with a single embryo, but some days after that embryo went inside of you, the embryo split. We don't like people having multiples. There are a lot of patients who will say to me, I don't care if we have twins. Oh, we don't mind having triplets. We just want to kind of get it over with. That is not something that we want for you. And the reason for that is that multiple gestation pregnancies are very high risk pregnancies. They are virtually guaranteed to have a preterm delivery, to have a NICU stay. There is a higher incidence of birth defects, of autism, of all kinds of problems, lifelong disability even. Now, everybody knows someone who has twins. And those twins, you know, as they grow up, they do great. They're friends together. They look alike. Maybe they do. Maybe they don't. Maybe they're fraternal twins. Everybody knows somebody with twins, and they've done okay. But you may not see the other stories, and those are the kinds of things that you see in the NICU, and those are the kinds of things that you see in an OB practice that we don't want you having multiples, because the environment is just more stressful. And I say sibling rivalry is a thing that begins in utero. The embryos will start to fight with one another. And especially in the situation that you had there, Alicia, where you had an embryo, you put in one, and then that embryo split and became two, tells me that that's a very challenging environment, because they also share some blood supply. It's a very high risk environment for the embryos, and I think that's probably what happened there. But gosh, I'm so sorry that you had to go through that. But yeah, I do agree. You know, that said, I do want to say something else about multiples here, that sometimes people will put in more than one embryo, and there are times when that's okay. There's some guidelines we follow from the American Society for Reproductive Medicine, and those will tell us when, you know, statistically we have a higher probability of having multiples. We want to avoid that if we can. If there are, I think I just totally lost my train of thought there. But if there's more than one embryo going in, we put in one can become two. If you put in two can become four. 4 can then split again and become 8. I have seen that happen. And trust me, friends, that is not something that you want for yourself. That is an extremely high risk pregnancy with really the potential for very devastating kinds of outcomes. Very special hello to Angelina Foxy up there in Minnesota, the most wonderful most wonderful cardiovascular nurse practitioner I have ever encountered. She helps people with broken hearts, don't she? That's right. Shanna says the miscarriage was incomplete after several weeks, 2 rounds of medication, and a D&E will be on Friday. I'm nervous about the potential scar tissue and damage for the next FET. So, gosh, that is just, Shanna, I am so sorry that you have had to go through with that. So, Shanna got pregnant, and unfortunately, the pregnancy stopped growing. When a pregnancy stops growing, we typically have 3 different options. One option is just to wait and let nature take its course. In nature, most of the time, that's what happens, that a miscarriage will commence, the body will pass that tissue. But sometimes it doesn't, or sometimes we wait for a while and it still doesn't do it in the timely kind of fashion that we want. So another option is that we can use medication. That medication is called misoprostol, or the brand name for it is Cytotec. And what that does is that it will cause the uterus the cervix to soften and to start to expel the pregnancy, although it doesn't always work there either. So then the other possibility is that we do it surgically, and that is called a D&C, a dilation and curettage. We usually use the term D&E, or dilation and evacuation, for a pregnancy that is a little bit farther along. So Shanna's asking about the risk of scar tissue from doing the surgical procedure. And I think it depends on how far along you are, Shanna, and you refer to it as a D&E. One of the things that I typically recommend if we're a little farther along in pregnancy and have to do a surgical evacuation of the uterus is to do it under ultrasound guidance. Because when we do it with ultrasound, there is less poking around. There's less scraping to have to be done. So we minimize the risk of potentially damaging that uterine lining. So I think maybe one question, Shanna, is to ask, are you doing this? Do you plan to do it with ultrasound, or can you do it with ultrasound to minimize the risk? Now, if it's a first trimester D&C, then doing with ultrasound is typically not necessary, and the risk for creating scar tissue in that situation is fortunately pretty low. But if you're beyond 12 weeks, the risk starts to go up, and that's a time that I think it's appropriate to think about using ultrasound. My thoughts and prayers are with you, Shanna, and again, I'm so sorry that you have to go through this, sincerely. Plant Honeys, hello, good evening, and hi to Audrey Kristen as well. Plant Honey says my TSH, that's my thyroid stimulating hormone. That's the hormone level we use to judge the volume knob of your thyroid gland. It's been below 2 for a long time. Baseline, it went to 2.71. My dose was adjusted, and now my TSH is a 3.8. I'm 1 week away from transfer. Is it okay to transfer, or should I wait? So I presume that means that you have hypothyroidism and that you are on the medication to treat that, which is generically known as levothyroxine or Synthroid. There are other types of thyroid that can be used to treat hypothyroidism. Now, I will tell you, and especially, if you were to go and look back at some of the archives of my broadcast, even, let's say 2 or 3 years ago, I would tell people that TSH, we're looking for your TSH to be in a specific range. That we used to think we really wanted it to be between a 0.5 and a 2.5. And we would constantly be trying to adjust people's doses to keep it in that range. Well, the evidence now tells us that nope, it's just not necessary. A 3.8 is almost a 4, and once it gets above 4, then it is back to being hypothyroid. So 3.8 is a little higher than I would want to see a TSH, especially if you're on treatment. But I would tell you, 2.71 is really probably fine. There are we do not need it to be any particular number for embryo transfer. There has not been shown to be improved outcomes if you keep that thyroid in a very tight range. So I hope that's helpful, because you can make yourself crazy chasing after these thyroid numbers. But I will tell you that there are some things that you can do. There's sometimes things that affect those thyroid numbers, because if you were doing pretty, once you're pregnant, your thyroid needs will change. The TSH typically will go up a little bit there, but so my first question would be, gosh, that's a pretty big change. I wonder at what time you took your pill relative to when you had the blood drawn. So if there is some variation in that, then really what we want is, I want you to get your blood drawn 6 hours after you took your pill. And you should be taking your pill on an empty stomach in the morning. So is the common wisdom. An hour before or 2 to 3 hours after eating. Take your blood 6 hours after you took the pill, and that should be the most accurate reflection of where your thyroid actually is. Yeah, boy, I'm just thinking, so much chasing around people's thyroids, trying to keep it in the right range. And then somebody wants it tested again. It's tested too soon. And then you're just going back and forth and doing all these changes. You don't have to chase thyroid too much. You just basically want to keep it in what the lab's reference range says is normal. And I'd have to wonder, given that you probably increased your dose when it was 2.71, why it's now 3.81, unless maybe there was just something with the lab, or it had to do with the time of day that you had your blood drawn there. So I do think it's okay for you to transfer, because it doesn't have so much to do about implantation. It has to do with how the baby's going to grow, and you have plenty of time to kind of correct that. But I might be apt to maybe test it again in that parameter 6 hours after you took the blood before. Beth TMT says, thoughts on an ERA, or an endometrial receptivity assay. My prior miscarriage in November of 2024, I had endometriosis excised stage 2 prior to the transfer. The baby was genetically normal according to the PGT, and was a day 5 tested embryo, trying to regroup and decide on which tests to do. So you're asking about something that's called an ERA, or again, the endometrial receptivity assay. A couple of years ago, this was really a thing, and this was part of the armamentarium that we had to offer people, because the theory was that there was a specific time during which we implant our pregnancies. And that time is the same in 75% of us, but in 25% of us, that time is different. And unless you do that test, you won't know if you're in the 75% or the 25%. Well, as it turns out, the endometrial receptivity assay was kind of shown to be a bit of a bogus test. What do I mean by that? Well, they studied 10,000 different pregnancies and embryo transfers. It was a huge study that looked at ERAs, and ultimately they found that whether that number was where they thought it was supposed to be, that's 120 hours of progesterone, or whether it was less than that, or whether it was more than that, it didn't make a difference in terms of embryo transfers. Now, we all had patients who just kept not getting pregnant. And then we did an ERA, found out the number was wrong, changed the amount of time of progesterone, and lo and behold, they got pregnant. And so it was a hard pill to swallow, but the study was very powerful and well received in the professional community. That really an ERA has very little place now for making any sort of determination. Now, that said, the ERA was really more for recurrent implantation failure more than it had anything to do with what causes a miscarriage. Because if the endometrium and the progesterone effect on the endometrium was adequate enough for the implantation to take place, then that's not the reason that a pregnancy would be lost. That's such a frustrating scenario as well, that you've got a euploid embryo, one that has given you a 65% probability of pregnancy, and you end up losing the pregnancy. Well, what we know is that they've tested the placenta of that embryo. They haven't actually tested the baby itself, but they've tested the placenta, and that the placenta is believed to be normal. So that tells us the chromosomes of the placenta are normal, but it doesn't say anything about any of those metabolic functions that are taking place inside an embryo. And imagine there are millions of little chemical reactions taking place at any given time inside an embryo. And if any one of those goes wrong, that can result in the embryo no longer being able to grow. And that's what's thought to lead to many of those pregnancies. So, Beth, I would say I don't recommend that you do an ERA, not only because the data doesn't support it, but because the particular scenario that you're describing was not the optimum one in which an ERA really would have been used anyway. But again, thoughts and prayers go with you, friend, because there will be happier times ahead, and just sorry that you had to deal with that. So fingers crossed, right? Everybody together. We got a lot of folks on the program tonight for whom I think we should all be thinking very positive and happy thoughts for happier times ahead. And as you'll hear me say at the close of my show, tomorrow is indeed a new day full of all new adventures. So fingers crossed there, Beth. Is a carrier of fragile, if a carrier of Fragile X, it was on the low end of the sequence, should I do PGTM? Could this also be the reason my AMH is low? Okay, so I think you're saying that you were probably found to have what's known as a pre-mutation for Fragile X. So the way Fragile X works, Fragile X is a genetic disease. It's the most common cause of what they call sex-linked mental retardation. So unlike Down syndrome, which is trisomy 21, that's 3 of the chromosome 21, Fragile X only happens on a piece of the X chromosome. And what happens is that there are a number of repeating little sequences of genetic code. And normal, there's a bunch of repeating, I forget what the numbers are. Normal, there's a bunch of repeating sequences, and we all have the same repeating sequence. Some people have more repeats. And if you have more repeats, then that may be what's considered a pre-mutation. And then as the offspring, or as the generations continue, that number of repeats can continue to increase. Whereas someone who has beyond the threshold of the number of repeats of that sequence, they are said to be affected by the Fragile X. So Fragile X, if you are sort of a carrier of Fragile X, is one of the things that we check in women who have premature ovarian failure. And that is to say, kind of menopause that happens before the age of 35. So, Andre, is that a cause of, what just causes an AMH to be on the lower side? It's hard to say that that's the truth. And you're saying on my genetic test, I had 2 repeats on the lowest end of the sequence. So I think that means that, you were probably just a little bit beyond what's normal. So that's not the sort of thing that should affect you or your offspring, or likely your offspring's offspring, but potentially it has effects, can have an effect several generations down the line. So That was a close one, right? That certainly must have been something that made you nervous, I'll bet. I am Freckles. I like the name. Hi to Michaela Marie. Marlena says, for those with a short luteal phase undergoing medicated cycles, not IVF, do you recommend progesterone supplementation? So I think you're talking about. So actually, let's just answer that in so that everybody understands. So if you're doing a fertility cycle, let's say, normal circumstances, you've got two phases of the menstrual cycle. There is the follicular phase, and that's where you're developing a follicle. And what happens at the beginning of the cycle is that the brain starts screaming at the ovaries, and it says, give me a bunch of eggs. And the ovary says, okay, I know how to do that. And it scoops up a bunch of eggs, and these eggs are going to hang out together and fight with one another because one of them is going to be the one that emerges as the egg that gets released, the egg that you're going to ovulate. All right, that's kind of the way I think about it. We can measure that number of eggs, and that's what's known as the antral follicle count. If you've ever had an ultrasound in the beginning of your cycle, when we're counting that number of little egg houses, that's really what it's for. So until you ovulate, you're in the follicular phase. When the ovary releases its egg, then you become in the luteal phase, because that space that gets left behind when the ovary releases an egg is called the corpus luteum. So your corpus luteum's job is to make progesterone. It is a little progesterone making factory. That's what it does. In most cases, there can be variability in the length of time in your follicular phase. That your follicular phase may be 12 days, it may be 14 days, it may be 16 days. But the luteal phase is almost always 14 days. Now, there are some people who have shorter luteal phases. And what happens in that scenario is that their progesterone may not be adequate to maintain a pregnancy, or their progesterone levels may start to drop before we want them to, or that the progesterone effect on the uterine lining itself is just not doing it right. So in that situation, let's say you're doing an ovulation induction cycle. So that alone, in most cases, is enough to fix that progesterone problem. However, if you're known to have a short luteal cycle, absolutely, a short luteal phase, I say, absolutely, I would give you extra progesterone. So what form of progesterone should you use? I would certainly recommend vaginal progesterone, because doing it orally has a systemic effect, but really where we really need that progesterone to do its job is locally at the lining of the uterus. So micronized progesterone, or what is brand named as Prometrium, can simply be placed inside the vagina. It's a funny shape. I'm sure you've seen it before. Probably it's a funny shaped little pill. Looks like a little egg. Tuck it on the inside. Do it before bedtime. Sometimes we'll have you do it twice a day, and that is typically enough to take care of that progesterone business. I think certainly in the fertility world, a little extra luteal phase progesterone being delivered vaginally is a very reasonable and inexpensive thing to do. Now, there are other types of progesterone that you can use. One's called endometrin. The other is, that's the one I typically use, and I'm blanking on what the other one's called because I don't use it very much. And they're expensive. Those progesterone creams are really expensive, and you may find them more frequent. A Crinone is the other one. Thank you. I was just blanking on it. You'll find those more used in IVF, where you have an embryo and where you're not making any progesterone, and we need to be very, very precise with how much progesterone you're getting. But in general, I haven't seen anything that says there's any problem with Prometrium because your insurance covers it. You go get it from Walgreens. You don't have to get it from a specialty pharmacy. And it's a lot less messy than a cream. You just take that little egg-shaped pill and tuck it on the inside. So Marlena, yeah, I would say a little extra progesterone. Prometrium is probably the one I would use. Oh gosh, Michaela is saying, I'm sitting here holding my 5.5-month-old from the second egg retrieval with you. I love to hear that. Thank you. Thank you, Michaela, so very, very much. I really appreciate it. Lovely Onyx says, thank you so much for constantly showing up here to help out. Oh, thank you. I have my 7-month-old. You've always answered my questions. God, I love to hear that kind of feedback. Thank you so much. You're going to make me get all teary here. So really, truly appreciate it. We're going to be about out of time tonight. If I wasn't able to get to your question, please email me, and that's askfertilitywithfink@firstfertility.com. Ask Fertility with Fink at firstfertility.com. We will be back next Tuesday at 5 o'clock Central, where we are every Tuesday evening, and I sure hope we'll have the pleasure of your company joining me. Remember, this whole thing about fertility is not the book of your life. It is just a chapter. And what are we doing? We are here to rewrite that chapter together. So until next time, every step forward with kindness. There is not enough kindness in this world. Do something nice for a stranger, would you? Make a difference in somebody's life. Smile at someone. You just never know what kind of day they're having. Somebody you don't even know. Every step forward with love, and every step forward knowing that tomorrow is indeed a new day full of all new adventures. So until next time, I'm Dr. Randy Fink. Thanks for being here. Good night. See ya.